Okay. There.
Sure, McDonald's breakfast is good. But getting that McDonald's breakfast 2 minutes before it stops being served, that tastes even better.
Hey, a few more minutes, then we'll start for today. So we're going to do the other half of chapter 8 today. Pumpkin, what is that, pumpkin?
It's just Americano with pumpkin.
Pumpkin season, right?
Yeah.
Pumpkin everything.
I was gonna, at some point, I was reading together, I just like totally got my mind. At some point, I was
Oh no.
I've never.
Have your favorite spots in the building? I see the same students consistently.
Yeah.
No, oh, no, it is.
Nice.
That would have been very sad.
This building does have nice windows though.
I do like this building.
Oh, yeah. No. We had
Guess we better start.
Or it was, because I mean, it was fun.
Yeah, it wasn't special.
But like when we were
All right, welcome. How's everybody doing? Good? All right, so chapter 8, part B today. So next week, chapter 9. The week after that, I'll be traveling, so we'll have assignments posted on D2L. Nothing too work intensive, but we won't meet that week for lab or lecture. So that's not till election week. So next week, everything just like normal. For lab next week, we're shifting down to the lower body. So it's going to be rectus femoris, which is front and center. So the electrode placement goes right in the middle between, halfway between the ASIS, what does that stand for? Yes, anterior superior iliac spine, and the top of the patella. So guys, just kind of carve out a little spot there. And then vastus medialis over on this side, we'll put an electrode there. So squats and leg extensions for EMG next week. And then after I get back from traveling, we'll do quantitative EMG analysis. So we're just looking at the subjective part and practicing our electrode placement and preparation, and then we'll go with a spreadsheet where you'll actually learn how to do an analysis and chop down a spreadsheet into a manageable form that you can analyze. So, do you have any questions? All right, so Let's continue on then. I have an activity, but that doesn't come till later, so I need to go through this stuff first. Okay, so we've been talking about landmarks for origin and insertion. So muscles typically have 2 points of attachment. We also need to consider that muscles connect to each other. So there is a skeletal attachment, but muscles oftentimes will connect to one another as well. So we have force transfer that takes place all through the body during movement. So in terms of the insertion points, the gluteal muscles, the 6 deep external rotators, they all have attachment points on or near the greater trochanter. So remember, that's this very large bony process on the lateral side of the hip. So if you palpate, you can feel that's pretty prominent near the skin surface. Iliopsoas. So the iliopsoas is actually a group of 3 muscles. So the psoas major, psoas minor, and iliacus. And so the insertion point for that is on the lesser trochanter. So you can see that one right here. And notice there's a crest. So the intertrochanteric crest between the greater and lesser. And so the gluteus maximus actually has some fascicles that have attachment along the intertrochanteric crest. The hip adductors, pretty much all of them. All your adductors, adductor magnus, brevis, longus, pectineus, gracilis, several adductors, they all have insertion points somewhere along this linea aspera. So that's a raised ridge of bone that is very prominent along the posterior aspect of the femur here. Okay, so proximal tibia or fibula. So we're going to the distal part of these muscles that act on the hip and also sometimes the knee joint. Hey, Brian. And so a very good test question, guarantee this will be on the next exam. I'll ask you to list the muscles of the pes and serenus insertion. Pes and serenus insertion. So you can remember that that's the sartorius, gracilis, and semitendinosus. So the upper medial part, just below the medial tibial condyle. And so if we take a look at that, that's these 3 muscles right here. So their tendons distally blend together. So sartorius, gracilis, semitendinosus makes up the pes and serenus insertion. Okay, so the semimembranosus and semitendinosus. So our semi-muscles, part of the hamstrings, they are posterior and medial on the tibia. So as you're sitting there in your desk, you can place your fingers there and you can feel those stringy tendons. That's why we call them the hamstrings, is because they have those stringy type tendons on the medial side here, just inserting here on the medial tibial condyle. The biceps femoris is on the lateral side. So now if you go over to the lateral side, and you can palpate the tendons of the bicep femoris here. Some of those tendons have attachment to the fibular head. So the fibula is lateral, tibia is medial. So this is the fibular head right here, and you can see some fibers attaching there as well. The iliotibial tract, that's a big long tendon that connects the tensor fascia lata. Has a special attachment point. So again, another good test question. The insertion of the tensor fascia lata is on the Gerdy's tubercle. So let's take a look. That's what this looks like right here, the Gerdy's tubercle. So if you have an opportunity in another class, if there's a skeleton available, you'll see on the lateral side of the tibia, anteriorly, there's kind of this raised part of the bone where the tensor fascia lata attaches via the iliotibial tract. Okay, so I always like to bring in a practical study, and we're doing EMG this week. So one of the great parts of EMG is we can look at different regions of a muscle. So we have standardized markers for the muscle as a whole, but maybe we want to look at different regions. So this study done 7 years ago looked at the proximal and distal aspects of the medial and lateral hamstrings. So the stiff-legged deadlift, sometimes called the Romanian deadlift, which is a hip-dominant exercise for the hamstrings, and the lying leg curl, so also known as the prone leg curl, and that's a knee-dominant exercise. So the load that they chose to use was an 8-rep max, so moderately heavy, which is nice, because a lot of EMG studies, they tend to use lighter weights that aren't really relevant to practice. So this is good because they're using loads that are more consistent with what we do in reality. So we're looking at 4 different electrodes. So if you can imagine your right hamstrings, 4 electrodes, 2 placed proximally, and so that would be the upper lateral as well as the upper medial, and then 2 that are placed distally, so that would be the lower lateral as well as the lower medial. So kind of like making a box on your hamstrings. So you have 2 up here by the hip and 2 down here by the knee on the medial and lateral sides. So you could hypothesize that with the leg curl, that the lower electrodes would be more active or show more activity, just because it's a knee dominant exercise with a leg curl. So they did have findings that were consistent with that hypothesis, looking at the lower lateral hamstrings. You can see here the what they call the lying leg curl, prone leg curl, and the stiff-legged deadlift, SLD. And so for the lower lateral hamstrings, so we're talking about which hamstring is on the lateral side? You remember? Yeah, the biceps femoris. Okay, looked like it showed more activity during the leg curl for that region. So if we go over here, lower medial hamstrings, which would be semitendinosus, semimembranosus distally. So the asterisk, if you have statistics, that is commonly used to indicate a significant difference between conditions. So far for the leg curl, we have findings that are consistent with their hypothesis that a knee-dominant exercise tends to target a muscle close to that joint, like the leg curl. So the findings were a little bit different when you look at the upper part of the hamstrings. So for the upper lateral hamstrings, there wasn't a significant difference. There was more activity favoring the leg curl for the upper lateral hamstrings, which is kind of different than what the hypothesis was, as well as there wasn't a significant difference for the upper medial, a slight increase favoring the deadlift on that one, but not significant. So kind of a hypothesis that was partially supported, partially not, but lending support to the idea that we want to do multiple exercises for a given muscle, because the activity, the way that the nervous system activates those muscle fibers can be different for the same muscle group. So it's good to include a variety of exercises for every muscle. Okay, so joint range of motion, there's some disagreement. There's always disagreement, isn't there, in science? But it's good, because if you have 2 sides, then you know that everybody's thinking and putting effort into it. So people are different anatomically in hip joint designs. Remember all those slides that I showed you the other day with all the different ways that the hip joint can be structured. So that can significantly affect range of motion. So we're looking at a pretty broad range here for hip flexion. In hip flexion, we oftentimes assess with the knee flexed. And the reason has to do with passive insufficiency. So as opposed to active insufficiency. So passive insufficiency is a muscle is excessively lengthened over both joints at the same time. So in other words, if we flex the hip and extend the knee at the same time, you can imagine, you can try that while you're there, extend the knee and flex the hip, and what happens with the hamstrings? It's really lengthened out, tight, right? That's the way we stretch the hamstrings, which is good, but that's going to mask what the true range of motion is at the hip because the hamstring prevents as much hip flexion as you're capable of. With hip extension, we're going from a prone position, so this would actually be beyond the plane of the body, so it would be hyperextension. So 0 to 120 of hip flexion, and then 0 to 30 of hyperextension. Okay, so the passive insufficiency of the hamstrings can be a risk factor for hamstring strains or hamstring pulls. So a sprinter is most likely to pull a hamstring when the hamstrings are maximally lengthened. So taking the hamstrings and stretching them from both attachment points. As you see here, this is the late swing phase as the foot is coming down to make contact. The hamstrings are lengthened over the hip and knee joint at the same time. So the knee extended with the hip flexed is placing a lot of strain on the hamstrings. So we want to try to mimic that as much as possible. So certain exercises that we do a good job of that. So glute ham raises, a really good way of doing that because you're flexing the hip and extending the knee at the same time. So, okay, so in terms of frontal plane motion, abduction and adduction, 0 to 35 degrees of abduction. This even shows 45 degrees. So there's a little bit of variability. And then 0 to 30 degrees of adduction. So we could even call this hyperadduction because we're going across the midline of the body there. Internal and external rotation. We talked about the structure of the hip joint and how that can affect rotation. With 0 to 35 of internal, this is on average, 0 to 45 degrees of external. Okay, so now we're going to talk about the corresponding actions of the pelvis and the hip joint. Because the lumbar spine also connects to the pelvis, it's impacted as well. So this is a little bit more complicated, not quite as straightforward as what we had with the shoulder joint and the shoulder girdle. So the front page of your movement and muscle handout is pretty straightforward. If the shoulder joint is doing this, the scapula is doing this. This area is just a little more complicated, so we're going to do an activity a little bit later to practice. So you have pelvic girdle rotation or tilt. So we want to use those two terms synonymously, rotation or tilt. So we have an anterior pelvic tilt, which would be anterior rotation. We have a posterior pelvic tilt, which would be posterior rotation. So use those terms interchangeably, but also we can potentially have action at the right hip, the left hip, and lumbar spine as well. So the spine attaches to the pelvis at the sacroiliac joints. Okay, so the lumbar spine, the pelvis are connected, and then the femur is connected to the pelvis at the acetabulum. So 3 different parts can potentially be affected here. So this point right here is really important. I should have highlighted that whole thing, but the body part that moves will be the part not stabilized or fixed. The part not stabilized or fixed. So what does it mean to stabilize or fix something in the context of muscles? Yeah, so muscles will develop tension isometrically to keep a part of the body or a segment of the body from moving, and then all the rotation or movement takes place at other segments. So we're going to go over several examples of how this works. So the lumbopelvic segment, the lumbar spine and the pelvis together, so that oftentimes is considered one part. The lumbar spine and pelvis make up one segment. So that part, that segment, is often fixed with the movement occurring at the hip joint. So we're going to show you some examples. So I know just reading that sounds a little vague. Just be patient. We're going to go over some examples. So sometimes the hip joint is fixed. Okay, so the femoral head is fixed with movement occurring at the lumbopelvic segment. So sometimes it's a lot easier to visualize the hip joint movement with open chain actions. So what's an open chain action? Yeah, what is not fixed? You're on the right track. It could be the, so I would say the foot, just the most distal part. So if the foot is not fixed and I'm flexing the hip and extending the hip and flexing the hip and extending the hip, okay, the lumbopelvic segment is fixed. And how is that fixed? So if I'm flexing my hip and extending my hip, how do I want to be right across here? Nice and braced. Yes, so we brace. The lumbopelvic segment is fixed because we brace. And then that enables effective action to happen at the hip joint. Okay, so the bottom here. Sometimes the hip joint is fixed. So closed chain, right? If my feet are planted, the hip joint, the femoral head is fixed, and then my rotation takes place with the lumbopelvic segment. It's still hip flexion, isn't it? I'm flexing and extending. The reverse of that would be I'm flexing and extending. So everybody understand the difference? Closed chain, open chain. It's still hip flexion, but different perspectives. Okay, so the pelvis is a very dynamic structure. It can rotate in all three planes: sagittal, frontal, and transverse. So sagittal plane is a little easier to visualize because we're tilting forward and we're tilting back. The transverse plane is a little more difficult. So the author of your textbook likes to use the steering wheel analogy. So if we're looking down on the pelvis, so this would be a superior view. So you can see the top of the sacrum here. You can see the symphysis pubis up here. And so what we're talking about is rotation of the pelvis in the transverse plane. So what's the axis for the transverse plane, remember? Yeah, vertical, or sometimes called longitudinal. So the pelvis can rotate in the transverse plane. It can also move in the frontal plane. So take a look. This is a posterior view of the pelvis. Okay, so you have the sacrum, the left hip bone, the right hip bone, and so on. So we're taking a look at the posterior view, and the pelvis can tilt side to side in the frontal plane. So let me pause it. Are there any questions? So is this making sense so far? Do you understand the pelvis can rotate in different planes? Okay, all right, so let's take this a step further. So here's the table. All right, now, this is one of those cases where what you see in the textbook isn't necessarily what actually happens in real life. So how will you know when to take this versus what actually happens? I'll tell you when you can look at the table versus not, okay? So we have sagittal plane actions at the pelvis. So an anterior tilt and a posterior tilt. Notice that we also could potentially, not always, because remember, certain parts can be fixed, but we can potentially have movement of the lumbar spine to correspond with movement of the pelvis. We can also have movement of the right hip and the left hip to correspond with these actions. Okay. In reality, I won't say never, but almost never, are we going to have all three, left hip, right hip, lumbar spine, and pelvis, doing all these things at the same time. Just not realistic. Usually, one or more parts is fixed, and it's just one part that's being moved. Does that make sense? So the lumbopelvic segment is fixed while we have action at the hip joints. So yes, this table is useful, but only to a point, because practically speaking, we're not going to have movement happening at all 3 points at once. So that's what this is for. So we're going to do an activity later to show that. So to give you kind of an idea, I've got this good morning exercise. So I want you to just, I've got this clip. And so, good morning exercise. So let's start. Closed chain or open chain? Closed, because the feet are fixed. The feet are planted. So the femoral head is going to be fixed, and we have rotation of the lumbopelvic segment about the femoral heads, right? Okay, so very important. Bracing is very important because that's going to help us keep that lumbopelvic segment stable. Okay, so this is a really nice animation. It kind of shows you've got, of course, the gluteus maximus, and then the lateral side. What part of the hamstrings again? Lateral bicep femoris. And then on the medial side, they're kind of hard to differentiate. The semitendinosus is on top. The semimembranosus is a little bit underneath and more medial. So semimembranosus is medial and then deep to the semitendinosus. So you can see our hamstrings here. Now, with a good morning exercise, you're placing the hamstrings on maximal stretch. At the bottom position, the hip joint is flexed and the knee joints are extended. So I want you to watch the tendons here of the hamstrings as it lengthens out. Like rubber bands, it's going to reach maximal length here at the bottom of the good morning exercise. So what are these other muscles up here? These fascicles that come down. Remember?
Erector spinae.
Yes, good, erector spinae. So that's a whole group of muscles that we don't get to talk about till chapter 11. So we'll get there, but let's focus on the hamstrings and gluteus maximus for now. Okay, so just up and down. Notice the stretch right there happening with the hamstrings. They attach semitendinosus, semimembranosus. Long head of the bicep femoris attaches to the ischial tuberosity. So the short head of the bicep femoris is the only one that's not acting over the hip and knee joints. So you can show a sagittal view here in a moment. Okay, look at the amount of stretch. So we have the lumbopelvic segment. Lumbopelvic segment is fixed. So that's one segment. And so that's stabilized through this bracing type action. Okay, so everything around here is braced. So lumbopelvic segment is stable, and then we have this pivoting action about the femoral head. So notice the stretch that you see here in the hamstrings lengthening over both at the same time. Let's see what happens if we're not braced. See what can potentially happen, and it's not good. show here in just a moment. Okay, so circle here. This is just showing you the pivoting action of the lumbopelvic segment, lumbar spine and pelvis together, lumbopelvic segment about the femoral head. So the femoral head is fixed, and it's this lumbopelvic segment that's rotating about the femoral head. Notice at this point that the pelvis and lumbar spine, we could say, are in neutral. So how many of you are familiar with this concept of a neutral spine? So we sometimes call it the neutral zone. So the pelvis is not tilted in any direction. The spine is not hyperextended or flexed. It's just has just a slight amount of extension in the lumbar spine. So that's where we're at right now, is this nice little bit of extension with the pelvis in neutral. So let me ask you a question. What if you have very tight and inflexible hamstrings? Is that going to be a problem on this exercise? Yeah, it's going to be a severe problem because tight inflexible hamstrings are going to do what at this attachment point? You're going to pull down, which is going to do what to the pelvis? It's going to tilt it back, which is going to do what to the lumbar spine? It's going to cause it to flex. You're going to get lumbar flexion, posterior pelvic tilt, due to lack of flexibility in the hamstrings. So notice how one compensation on one part can affect the other parts as well. So this says, okay, so hamstrings, normal flexibility, the pelvis is in a neutral position. So very important. That means you're braced. You're locked in, you're ready to go. Okay, so preservation of the lumbar lordosis. So that means just a slight amount of extension. Not too much. We're not talking hyperextension, but just a little bit. Okay. So this is if the hamstrings are inflexible. So can you see how the change in position with lack of flexibility in the hamstrings, you have adjustment taking place. If the hamstrings are not flexible, they're pulling down on the back of the pelvis, which does what to the pelvis? It's going to tilt it back, which in turn does what? What happened to the lumbar spine now? We're out of that neutral, natural lordosis, and we're in flexion, which places all kinds of stress on those spinal ligaments and discs. In fact, we have this response called the flexion relaxation response, where we actually, in this type of position, we have muscles that are turning off that control the stability of the spine. So you don't want to be in this type of position with your spinal muscles inactivated, because then all the stability demands go onto the joint facets as well as those ligaments and discs, which is when we have injuries. Let's just keep following this through. Okay, so it says inability to stretch. The knees are going to go into probably hyperextension. Okay, posterior pelvic tilt, showing the stress on the discs. Okay, so then contrasting that, hamstrings without the ability to stretch versus with is. Okay, so can you see how the segments are all connected? Okay, so what can you do? So in a situation of short hamstrings, so inflexible hamstrings, knee flexion allows a little bit of substitute for that. So you'd want to have a little more knee flexion, allows anterior tilt rotation of the pelvis. So we're able to get the pelvis back into a neutral position. And that is muscles in motion. So any questions on that part? Okay, so you can rewatch that anytime you want. So let's talk about mechanical differences in hip extension. Okay, so both of these exercises from this picture to this picture to this picture involve, as we've been studying from day one, involve extension. You should have your hip extensors memorized by now. So there are 4 of them, right? So the lumbopelvic segment is fixed. So in this case, it's the femur that is rotating about a fixed pelvis. Okay, in this case, it's the femur that is fixed. The femur's fixed, the lumbopelvic segment rotates about the femur. So there's a difference here. It's both hip extension, but we're talking about 2 different parts, lumbopelvic segment versus the femur, and in this case, it's the lumbopelvic that's fixed, the femur rotates. In this case, it's the opposite. Yes?
So then would the right be an example of a closed
Yeah.
one? And then that would be,
Mm-hmm.
okay. trying to
Yeah,
clarify.
so open chain, right? And closed chain is correct. Good.
Is there research over which rotation is better?
I don't think so. You always come up with the best questions. Everything that I don't know. Okay, I gotta study harder before this class. Okay, so hip flexion, mechanical difference. Let's drive the point home here. So lumbopelvic segment is fixed. The femur rotates. So again, we got a brace to fix. This is an open chain. Okay, so in this case, I guess we could call this closed chain because the feet are planted and the hips are planted. But in any case, the femur is fixed and it's the lumbopelvic segment that rotates. So in both cases, it's still hip flexion, still the same muscles, it's just opposing segments of the skeleton that are fixed or moving respectively. Okay, so guess what? More research, right? So what is the optimal strategy to fix the lumbopelvic segment? So let's talk about it. So a couple of studies done in Japan. There's some great muscle studies that come out of Japan. I can't even pronounce that. Teyashiki et al. 2016. Intra-abdominal pressure. What's intra-abdominal pressure? Yes. Within, we have this abdominal cavity, right? The abdominal cavity, and it has surrounded on all sides by muscles. So we have walls of muscles, we have a roof of the abdominal cavity. What muscle forms the roof of the abdominal cavity? Right on the bottom of the rib cage. Diaphragm. And then we have the pelvic floor muscles, those 6 muscles of the pelvic floor that make up the floor of the abdominal cavity. And then you have all of these muscles, anterior, laterally, posterior, that make up the wall. So the intra-abdominal cavity is kind of like a barrel, a fluid-filled barrel. And so when we tighten our muscles, okay, when we get activation of these muscles, that increases the fluid pressure in the abdominal cavity. Okay, so that's very important to provide a stabilizing effect on the lumbar spine. So fluid pressure from activation of muscles is what stabilizes the spine. So a couple of different strategies were examined here, again using electromyography. Okay, so very important. Bracing versus hollowing. Okay, so what's bracing? Like we talked about, tight, right? Tight. What's hollowing? Okay, everybody take your fingers, put them on your umbilicus, okay, and draw it back. Okay, the abdominal drawing maneuver. So the classic activation of the transverse abdominis muscle that draws the umbilicus back. So that's what abdominal hollowing is. So let's take a look. So looking at the change in IAP, intra-abdominal pressure. Okay, so bracing versus hollowing. So you can see bracing was more effective at eliciting a change in that pressure. So the stabilizing function of these muscles is greater when bracing versus hollowing, in other words. Okay, so now we're looking at muscles. So tell me what you think RA stands for. Yes, Thomas, EO. External obliques, IO. Yeah, ES. I just mentioned it a few minutes ago. Yeah, erector spinae. So looking at different strategies, so bracing is the darker bars, the lighter bars, hollowing. So you can see that by far the preferred stabilization strategy is a brace, except perhaps in the beginning stages of rehab. If you have a back injury and you're in the beginning stages of rehab, you may want less muscle activity just because you're working back into things slowly and you have passive tissues like ligaments and discs that are still in the healing process. You may want something a little more mild, which would be more of a hollowing type maneuver. So hollowing good for the initial stages of rehab. In practice, the bracing is probably preferred with healthier people. Okay, so same group, Teyashiki et al., they did a follow-up study. Okay, so what if you did a bracing type program in addition to other stuff you're doing? They had an experimental group, treatment group, and a control group. So two groups, treatment and control, like most experiments. So they were all doing their training, but in addition, the treatment group was doing a bracing type of intervention. So let me show you. So the training group conducted, in addition to their normal training, an 8-week training program, 3 days a week, consisting of 2-second maximal abdominal bracing followed by 2-second muscle relaxation, 5 times 10 repetitions a day. So basically they're just practicing the bracing technique over and over and over again. So they're just, at some point of the day, as a supplement to their other training, they were doing bracing. Okay, so it appeared it made a pretty big difference. So if you look at the treatment group versus control group over here, looking at force and torque, so those are, we talked a little bit about torque. Treatment group, force and torque, control group, force and torque. So we can see that the treatment group was able to improve their hip extension torque. So very important, both the treatment and control doing exactly the same training program with the exception that the treatment group was practicing how to brace. And so we can see that over 8 weeks they improved their hip extension. Okay, they also improved their trunk extension, okay, significantly so. If we go over here and look at measures of power, I think in this study it was something like a vertical jump test where they looked at power. We can also see that the treatment group learning how to brace, transferring force down the lower extremities and into the ground, because the more force we apply to the ground, the more force the ground applies back to us, they were able to improve power significantly as a result. So bracing appears to be the best strategy, very important. So at this point, what I'd like you to do is for your notes, as we prepare for that next exam, I want you to make a table because I'll ask you questions on this for the exam. We're going to talk about the 7 two-joint muscles that have action at both the hip and the knee joints. So we're going to make a table of 3 columns. One column is going to be muscles, the next is going to be hip, and the next column is going to be knee, and then you'll have 7 rows. So 1 row for each of these muscles that has actions at the hip and the knee joint.
What were the columns, muscles, hip, and what?
Knee. So you'll have 7 rows, 3 columns. This will be a good study tool. So if a muscle has action at more than one joint, then active insufficiency, passive insufficiency become significant. So, okay, so row number 1, rectus femoris. Okay, rectus femoris, its action at the hip is flexion. Its action at the knee joint, anybody know? Yeah, extensions, one of the quadriceps. So flexion of the hip, extension of the knee joint. Okay, row number 2, medius sartorius. Okay, so it's a double flexor. It flexes the hip and flexes the knee joint. Flex and flex. Okay, so coming around the medial side, gracilis. Gracilis, one of our groin muscles, commonly pulled when we have a groin pull. It's an adductor, ADD, adductor of the hip, as well as a flexor of the knee joint. Okay, so coming around the posterior medial side, semimembranosus and semitendinosus. You can write those muscles on consecutive rows. Both of those extend the hip and flex the knee joint. Hip extension and knee flexion. So it makes sense then if we're coming around the posterior lateral side, the biceps femoris, just the long head, extends the hip and flexes the knee joint. So the short head just acts at the knee, the long head acts at both. So all three of our hamstrings, semimembranosus, tendinosus, bicep femoris, just the long head, extension of the hip, flexion of the knee joints. Okay, so our very last one, tensor fascia lata, is number 7. That one abducts the hip, and it also extends the knee joint. So abduction of the hip and extension of the knee joint. So is there anything that I need to repeat? Everybody good?
So the semimembranosus, semitendinosus, and biceps femoris are all the same. They do the same.
Yes. Just remember, just the long head acts at the hip for the biceps femoris. All right, so the muscles of the thigh are divided into 3 compartments. So going from the anterior to the medial side, we have all of our quadriceps. In addition, we have the sartorius, so the anterior compartment. The medial compartment is, as you might expect, would be all of our hip adductors. So the adductor longus, adductor brevis, adductor magnus, gracilis is in there. So all the adductors of the hip. So posterior, again, as you might expect, this is where we have all of our hamstring muscles in the posterior compartment. So with a blow to the thigh, with or without fracture, we can have damage to these muscles and get swelling, and we can run into what's called compartment syndrome. So in severe cases, that requires cutting into the fascia that separates these compartments to relieve swelling and pressure. If that goes unchecked, it can actually lead to permanent damage to muscles and nerves due to lack of oxygen and nutrients. Yeah.
I actually have a friend who's getting surgery today to get his second distal. He's getting his toe cut off because he's got that in his lower leg by his ankle, and he doesn't have good flow and stuff. The blood.
Oh, sorry to hear that.
Yeah. I told him to keep the toe, but
I hope he heals fast.
yeah. So we're trying to help him.
So yeah, very real, and without any fracture or other, you may not even know that there's significant damage other than it hurts, and it can lead to permanent changes if you don't get it taken care of. Okay, so how are we doing on time? Where are we? Okay, all right. So I'm going to go just a little bit longer. Okay, so hang in there. Then we'll get to our class activity. So just like all the other chapters, okay, you gotta memorize some nerves. So, but it's not too bad. You can group them all together. Honestly, the worst chapter is chapter 7 on nerves. This one is just kind of more like the shoulder, just, you know, 4 or 5 nerves and then muscles. So lumbosacral plexus. So lumbar plexus, sacral plexus together. So we're talking about the peripheral nerve roots. T12, what does T12 stand for? Thoracic, right? To the 4th sacral. That's 4. So these are the 5 nerves that you'll need to remember. So femoral nerve, obturator, superior and inferior gluteal nerves, and then the sciatic nerve. So we had that discussion the other day about the greater sciatic notch and the sciatic nerve and piriformis. That sometimes becomes a problem. So femoral nerve. So this should be easy to memorize, right? Everything anterior. So quadriceps, right in the front. You have hip flexors. So the iliopsoas, pectineus, and sartorius are all hip flexors. So everything right up front shouldn't be too bad. Femoral nerve just runs right down the middle, branches out to the different parts. You can see the vastus medialis and lateralis there. Vastus intermedius, which is underneath the rectus femoris. Pectineus is here. Sartorius is cut, but it has its origin up here at the ASIS. Okay, so obturator. So you notice a common action location. So all of the adductors, brevis longus magnus gracilis, and then the odd one out that you'll just kind of have to commit to memory would be the obturator externus. So obturator externus is, let's see, I had it right there. So this would be one of the 6 deep external rotators of the hip. So it's kind of the odd one there, but comes right down just behind the pubic crest here, and then it has branches that go to all those different adductor muscles. Okay, so superior and inferior gluteal nerves. This is all the gluteal muscles: gluteus medius, minimus, maximus, and then the odd one here, kind of on the lateral side though, so it's in that same region. Plus the gluteus maximus and tensor fasciae lati share a common tendon proximally, so it kind of makes sense they're together. But the inferior gluteal nerve is just the gluteus maximus. So that's these 2 little branches right here, the superior one and then the inferior one here. Okay, so sciatic nerve has 2 parts. So the tibial part is more medial. The common fibular part is more lateral. So the tibial part innervates the entire hamstrings group with the exception of one part. So you can see that one part, the common peroneal or fibular division, innervates that short head of the biceps femoris. So everything else with the hamstrings, tendinosus, membranosus, biceps femoris long head, and then you also have one that you'll just commit to memory there, the adductor magnus. So we can see the adductor magnus right here. It's cut. So there's so many muscles that are not fully shown in this diagram, but we have this big sciatic nerve that eventually splits. You can see the split right here. The common fibular branch and the tibial branch is here. Okay, so I want to take just a pause, give you a second just to kind of think and talk to each other. So for about the next 20 minutes or so, I'd like to get you into this activity. So the way that this works, you're going to go back to the table. This will be right here. So slide 39. I can just make it here. Okay, and it's not just looking at the table and filling in the blanks because, again, this is useful to a point, but I also want you to understand how things work in practice. So at times it's okay to look at the table, and what I'll do is you'll see in parentheses like medicine ball wall toss. So that's a very practical exercise. So that's my goal in this class, is say, okay, so what's in the textbook versus how things work in practice, see if we can bridge that. So you'll see in parentheses, use the table in chapter 8 PowerPoint. So that's a case where you can take a look at the lumbar spine rotation, pelvic rotation, right hip fixed position, left hip fixed position. So let me ask you a question. Can the hip be fixed in internal or external rotation? Can I fix the hip in an externally rotated position? Yeah, of course I can. So you want to think about that. It might be rotated a certain way, but it's not moving, it's fixed. So this it's going to require a little bit of extended thought. So there's some familiar exercises on here. So Romanian deadlift, so notice, don't want you to use the table. I want you to just talk about it, think about it, even stand up and do some to see how it feels and what you're sensing, the position of your pelvis and lumbar spine. Dumbbell side bend, there. Leg raise, prone hip extension, as well as windshield wipers. Okay, so trying to make this practical for you. So let's take about 20 minutes and then we'll get back together and go through the rest of those muscles from chapter 8. So I want some good discussion.
Your face is the same.
So, go weird. I mean, it's coming down and it's okay, well, think about it like versus if you start, like, I'm imagining, right, if you start standing facing the wall and then you turn over to it, so it's like, right?
So like the so you said the direction it turns is it's left or right?
Well, would it be easier to start with the pelvis?
So I'm just going to hold back for this 20 minutes, then we'll bring it all together.
Like your hips, they start and then get flexed, and your hips stay
So, when you mean lumbar spine rotation?
I'm going to hold back.
Okay.
Talk about it.
Because it's like
Because it's not. So this would be.
I think so.
Oh, yeah.
The right road, because I mean, the yeah.
All right, we're turning to the right.
Yeah, turning to the right.
Turning to the right.
Instinct.
Right turn.
So we can just look at what.
Yeah.
Oh, yeah.
and it would be left transverse. Oh, yeah, because
So it's both transverse, yeah, that makes sense.
and then
Because it's like, it's moving.
stupid. Your right hip is definitely an internal rotation.
Yes, it would be left.
I have I know.
Good job.
So right in that fixed position. No, they're right, not mine.
Has to be, otherwise you'd fall down, you'd lose your balance.
It's like as soon as you got the shoulder on the side.
Okay, so, your lumbar spine would be in flexion, right? Would be in flexion.
But if the pelvis,
Pelvis.
So remember, for closed chain, the pelvis rotates about a fixed femur. So it's, you have to imagine right and left hip rotation looks different in a closed chain position because it's the pelvis rotating about the femoral head versus the opposite.
I feel like it's definitely anterior, right?
Yeah, I think it's anterior.
Yeah.
Yeah, in this one.
So the femoral head is fixed.
Oh, I'm just not using that a lot. Because this one we could use the short, and this one we said not to, because they'll confuse you.
And then right when we get bilateral motion during the lowering.
Yeah. So when it's between right and left, bilateral. Or the opposite. Well, it'd still be the same action, it would just be. Just one more back.
That's what I think.
I mean, because both of them, they aren't using anything, it's literally just like. It's fixed around, so. Yeah.
See, if so confident talking about it, and then he's like gonna go over it, and we're like, oh. Okay.
Yeah, right.
Right lateral tilt.
You can still be in an internal external position.
Because it'll be kind of the opposite, because it's gonna have to cleanse it, because it's gonna go to the left.
Going
Or else
okay?
your whole body's just gonna fall over.
Think about how important neutral pelvis is. We're bracing to keep the pelvis locked in neutral.
Your lumbar spine is really fixed.
So neutral's not an option on yours, but
Is that an option? Yes, it is.
So we can sit neutral.
That's why I say sometimes use the table, sometimes not.
So we can use neutral. Because it's not using it.
Okay.
In many cases, you're not flexing. Yeah.
Pelvis fixed position.
so at the top here, the lumbar spine would be.
Practice.
Yeah, then we're gonna do neutral, because also that's gonna be happening is hip flex.
That's why I say when to use the
Spine's
table.
straight, you have to brace that part too.
So the Romanian deadlift's a lot like the good morning video that we saw.
Because they're both the same, they're both flexed.
Yeah, I think so.
Yeah.
No.
Yeah, then it would be.
What if it's just like?
Yeah.
So if you were to go back. Pelvis is doing something, right? I'm like, I can tell the right hip's gonna be an extension. It's actually like
It takes time.
hyper.
It does, you
So
have to
then
sit.
pelvis is just gonna stay.
It's over time, you see more and more about it.
It's saying it's fixed.
Started thinking about
It's like, no, it's laid out.
Yeah, if we're all gonna lay here and do it.
Every now and then, going full circle.
So technically, like, if you're good and you're strong, you should not, your head shouldn't lift up, it should just be your legs.
But I still feel like it's still a bit of a posterior tilt, right? Because when you lay down, that's not where like it sits in neutral. When you lay down like that,
Kind of a, I guess it can be fixed though, he said it can be fixed, it can be moved, but it can be fixed.
right, so that's why I think it might be fixed at like a posterior.
Yeah, I think, because this is an issue, yeah, when you lay it, it pushes the.
Yeah, right?
I'll take the other. Yeah, it can be fixed, but it can be fixed at. Yeah, that like that, because yeah, if it's kind of tilted.
I mean, is that?
I'm hearing some good things.
Okay.
What did you write?
We decided it's posterior because like when you lay down, like our thing is that it, your back.
Keep talking.
So it's fixed. Yeah. It's just deciding if it's fixed and neutral or if it is a bit of posterior. But if, yeah, I feel like it depends on the person too.
Yeah.
Because some
You're
people.
looking at him, so
If you're standing. Yeah, if you got, you got girls, then well, it's gonna mess all of us up.
That's gonna be my argument. Tab.
for some reason my brain's
Her spine won't be neutral.
I'm gonna do posterior tilt slash neutral.
We'll still do posterior tilt.
Yeah.
We're just gonna go
Yeah.
But if you have like a tilt on it, you'll stay.
And then your right hip.
Yeah, technically.
Yeah.
Good, it has to be opposite, because if they were both to the right, we'll have to both. One segment that
Oh, we can use the table.
counterbalances the movement of the other.
It's rotating towards. So then it'll be opposite for the one bar, because if one turns that way, you fall on.
So is it less transverse?
I think she's like, have to think so much when I do this exercise.
Yeah.
I think so, it's transverse, because it's just kind of.
That you're going around the vertical axis.
Yeah.
All done?
And then your lumbar spine.
Couple minutes, okay? We'll get back together.
Yeah, for the pelvic, and then if you look at the chart, and so if you think about it, the one bar will be doing opposite, so.
Yes. You never want to stop racing with that. Right. If you do it right.
Or else I just.
Well, it's over like. And I found that,
Yes.
like, I don't need the answers, I just need someone to talk to.
Or like perform it for me.
Hearing some very good things going on, good
It's
discussion.
like. You know, it has to be certain muscles, but with this, it's just like.
It's like a great, I'm sure we'll have to do that eventually.
Probably. I'm not gonna think about it though. I have someone.
I don't know, because every time you said it keeps getting pushed back, like we actually have to, I'm like, I can memorize it, I just haven't put the time
What
in.
happens here is both the pelvis and the lower spine.
So there was, just like the last test, it was gonna be. And then it was like.
Yeah, so you have to have one, if your legs are
Because, like, I
going
keep
one
on waiting
way,
for it to, like, come up,
your,
and, like,
the other part of your body has to go the other to counterbalance it.
Yeah, it's just the fact I haven't spent the time.
Yeah. Okay, makes me feel better.
Well, if we're going there, so I think that would be right.
Do that a little bit.
This also seems to be more central head and shoulder rotation gives.
Yeah, this, it's kind of like.
Yeah, that makes more sense.
Because this is more.
Are we ready? Ready, talk about it?
See, that makes it.
Yeah.
Okay. right rotation. So a lot of this has to do with counterbalancing torques. So if you put torque on one side of the body to maintain your balance, what do you have to have? A counter torque on the other side, so to keep equilibrium. So we're talking about segments that sometimes move or are fixed in opposite positions to maintain balance and equilibrium. So in this case, lumbar spine motion to the right. Okay, so the pelvis, to keep balance, has to do what? It has to rotate to the left. So according to our table, the very last row, if the pelvis is rotating left, we're in a closed stance position. So pelvis rotating about the femoral heads. The right hip will end up externally rotated in a rotated position, externally rotated position. Whereas the left hip, because the pelvis is rotating on the left femur, will end up in an internally rotated position. So imagine fixed femoral heads, but the pelvis can turn to achieve a rotated position. So joint actions a lot of times are taught in open chain positions because it's easy to say, okay, this is internal rotation, this is external rotation, but we're talking about open chain with the pelvis fixed and the femur rotating about the pelvis. But what about if the femur's fixed, okay, and the pelvis is rotating about the femur? It's still rotation, it's just different perspective. Questions on that one? Okay. So Romanian style deadlift, based on our video, if we're braced, so locked in a neutral position, that protects our back. Okay, so lumbar spine fixed position. You can say neutral or a slight anterior tilt. Slight anterior tilt. We don't want an excessive anterior tilt because then we have other problems with hyperextending the lumbar spine. So a slight anterior tilt or neutral position is okay, and we get that by bracing. Pelvis fixed position would be neutral or slight anterior tilt. Lumbar spine is going to be slightly extended or neutral. It's slightly extended when in neutral. Right and left hip bilateral motion. What does bilateral mean? Yeah, so both at the same time, so that's going to be flexion. The lowering phase is flexion. Okay, so dumbbell side bend, okay, just simple action. We'll get more about this in chapter 11, but it's right lateral flexion. And the pelvis, again, is going to be in neutral. So the pelvis isn't going anywhere, it's just fixed.
Do we have slight left lateral tilt?
I'd say so, yeah. Slight amount to the opposite side, just a little bit. Okay. All right, so leg raise. Okay, so the only reason this is considered an abdominal exercise is if you keep your brace. Because as soon as you lose the brace, it's all hip flexors, which are pulling on your lumbar spine. It becomes very dangerous exercise if not done correctly. So lumbar spine fixed position is going to be neutral or a slight posterior tilt. Neutral or a slight posterior tilt. The lumbar spine, so pelvis, I keep saying pelvis to start with, sorry. So neutral or a slight posterior tilt on the pelvis. Lumbar spine is going to have a slight amount of lordosis or just maybe going into a little bit of flexion, especially at the top of the movement. So as the legs come over the top, there's going to be a natural tendency to tilt back with a little bit of flexion in the lumbar spine. So we really want things just to be locked in place. Neutral is good because that places the least stress on discs and ligaments. So the lifting phase, what are we doing? Flexing the hips is right. Sure enough. Okay, prone unilateral hip extension. So we know what prone means, we know what unilateral means. Okay, so this one's a can be a little confusing. So pelvis is in a fixed position. The clue there, the erector spinae maintaining isometric tension. So the erector spinae, we've talked about a little bit today, but it pulls up on the posterior iliac crest. So if you have a muscle that's pulling up on the back of the pelvis, what's the pelvis going to do? It's pulling up on the back. It's going to tilt just a little bit. So we're going to go with a slight anterior tilt. Slight anterior tilt. Okay, so we're pulling up on the back side. So the pelvis is a bucket. Yeah. So it'll be just a little bit, just a slight anterior tilt due to the action of the erector spinae. So the pelvis has to be fixed that way or else we can't get full extension of the hip. The right hip motion is extension. So this is the first day you've probably ever thought about this stuff. So how many other things do you get 100% on day one? Okay, so practice. Okay, so windshield wipers, we're looking at back at the table again. So pelvic rotation, so the pelvis and the hips are going to the left. So what has to happen with your lumbar spine? There has to be torque that goes in the opposite direction. Otherwise, what's going to happen? You're going to fall over. So you have to have an opposing torque that counterbalances the torque from your legs going to the left. So legs go to the left, your lumbar spine has to create torque in the opposing direction to maintain your equilibrium. Okay. All right, so first exposure to that stuff. So I want you to keep that. I have just a few more slides, and then I'll let you go from there. Okay, so 6 deep external rotators. Not too hard to memorize because 2 of them are paired. So the gemellus, superior and inferior, as well as the obturators are paired in addition to piriformis and quadratus femoris. So don't confuse the quadratus femoris with anything here with the quadriceps muscle group. So they all have attachment points on different parts of the ischium as well as the sacrum here. And then insertion points just all down the intertrochanteric crest and greater trochanter. So something that's interesting about the piriformis is that it's an external rotator up to 90 degrees of hip flexion. So that's something that not a lot of people realize is that, yes, it is a deep external rotator, but only up to 90 degrees of hip flexion. So beyond 90 degrees of hip flexion, it actually becomes an internal rotator. So if our hips are flexed 90 degrees, greater than 90 degrees, in order to stretch the piriformis, we have to do the opposite of internal rotation. So if the hip is in greater than 90 degrees of flexion, to stretch the piriformis, we have to do the opposite of internal rotation, which is what? External rotation. So with the hip in greater than 90 degrees of flexion, we have to externally rotate at the hip to stretch the piriformis. So that's getting back to this. So what position is the hip in here? It's flexed, greater than 90 degrees, and it's externally rotated, which is why this is such a fantastic piriformis type stretch. Anybody tried this in this class? Help you? Yeah, every day. It's very common for students and especially professors to spend a lot of time sitting to have tightness there. So we want to work that out. Okay, iliopsoas. So this is a group of 3, psoas minor, major, iliacus. So notice the points of origin here along the bodies of the 12th thoracic and then all 5 lumbar vertebrae as well as these transverse processes. The insertion goes all the way down here, so they share a common tendon that goes all the way down here to the lesser trochanter. So anytime you have a muscle that inserts on the back of the hip or back of the femur, it's going to be an external rotator. It is involved with anterior pelvic rotation. If this muscle gets tight, it's going to be very painful on the low back, so that's why we have to do a lot of hip flexor type stretches. So can you see we're kind of developing these patterns where we have common muscles that get tight. It's almost like we should have a list of maybe 3 to 5 stretches we do every single day just for better health. This is one of them. So an iliopsoas stretch, a single joint hip flexor stretch. Have any of you done the couch stretch? Couch stretch, you know what that is? Yeah, so you're flexing the knee, extending the hip. A wall works really well, okay, for that. Look up couch stretch. I don't want to tear my pants, so I'm not going to do it here. But, okay, so rectus femoris. So anterior inferior iliac spine, so right here, AIIS, coming down all the way down here to the tibial tuberosity. So flexion of the hip, extension of the knee joint. Okay, so oftentimes we do this test. It's called a Thomas test. So a lot of you have probably heard of it. We're trying to assess the tightness of the single joint and multi-joint hip flexors. So we can tell if the rectus femoris is the problem or the iliopsoas is the problem. So rectus femoris is our 2-joint hip flexor. Iliopsoas is our single joint hip flexor as a group. So you place your client on the edge of this bench, and then you have them pull one knee into their chest. And so what you're watching for is the contralateral leg. And so if the leg stays nice and bent at this 90-degree angle, but the leg starts to raise up, that would indicate tightness of the single joint iliopsoas. If the leg stays where it's at, but the knee starts to extend, as you see in the outline there, that would be tightness of the rectus femoris. So that would be the 2-joint part. So if you have elevation plus extension, what would that indicate? That's a problem. That'd be both. So you really need to do some hip flexor stretches. So daily basis, we're looking at hip flexors is a common problem. Deep external rotators is a common problem. So these are just things you do as part of your lifestyle. So do you have any questions from anything we've talked about today? Okay, so we didn't quite make it through all chapter 8, but I want to make sure you're fresh for the last part on Monday. Remember EMG, going to the quadriceps, so come prepared. All right, thank you. Yes, sir. Let me turn the screen off so it doesn't have to grade up there. I can do squats. Do squats. Want to do body weight? Knee extension? Yeah, let's do that. I was just going to bring in some ankle weights in because we don't have a leg extension machine. Body weight squats would be good. Yeah, we're just talking. It'd be a goblet squat, so it's something that not too bad. Okay.
Yeah, okay, so your posterior radius.
No.
No, yeah, you're right. Okay.
Oh, yes, please.
Yeah.